Hello, friends. Welcome to this episode of AMR Dialogues. These dialogues are hosted by CNS and the Global AMR Media Alliance, or GAMA. AMR Dialogues feature conversations with AMR leaders from around the world, including AMR survivors, AMR scientists and researchers, and others engaged in raising awareness about antimicrobial resistance, which is one of the top global public health threats. Our guest for today is Dr. JOHN KARIUKI, a veterinary surgeon by profession. Dr. KARIUKI is Assistant Director at the Veterinary Public Health Division of the Directorate of Veterinary Services in the State Department for Livestock Development, Kenya. He is also a member of the WHO Task Force of AMR Survivors, as well as of the Kenyan National AMR Stewardship Interagency Committee that is charged with developing the National Action Plan on AMR for Kenya. Welcome, John. It is an honor to have you with us today. And we are really excited and we want to know your personal lived experience of the impact of antimicrobial resistance on the life of any one of us. So, your experience, John.
Thank you very much, Sobaya. I'm glad to be here with you today. It's my honor to be able to share my experience on AMR. Incidentally, I happen to have done my postgraduate studies on AMR long before I became a victim of AMR. And so most of the things I theorized in my thesis about AMR were called upon for me to put them into effect to recover from AMR. My ordeal started in October, 6th of October, actually, 2020, when I had an accidental slip and fall in my bathroom, which occasioned a fracture of the hip joint. Now, this fracture was initially misdiagnosed because the clinician who read the radiograph actually told me that there were no signs of a fracture, which to me was a great relief. And therefore, he went ahead and prescribed muscle relaxants as well as painkillers. But about 10 days later, the pain became more and more excruciating. And so I had to seek a second opinion from an orthopedic surgeon. And we decided to do a CT scan. And it is after we did the CT scan that we came up with a definitive diagnosis, which was a complete fracture of the hip joint. And so it was suggested that the intervention would be to do a hip joint, to do internal coaptation of the hip joint and rejoin the hip, rejoin the ball back to the femur using plates and pins. So I had to undergo an open surgery, which was, I think, a 4-hour surgery to put in pins and internal coaptations to rejoin the bones. And this was done in November of 2020, 18th of November 2020. And I spent about a week in the ward recuperating, of course, on prophylactic antimicrobials, specifically enrofloxacins. I was released from hospital a week later, and I was requested to come back for wound dressing a week later. After the dressing of that wound, I never recovered. And after about a week, I was then admitted to the intensive care unit with septicemia and the other complications that accompany severe septicemia. This included hyperglycemia or high blood sugar. So I was almost in a coma, and I was admitted the first week of December 2020 for 3 weeks, during which time the course of administration was using a negative pressure therapy machine which was inserted into the surgical site to suck off the discharge that was coming out from the surgical site. At the same time, I was on heavy antibiotics, both oral and intravenous. And then after 3 weeks, I was again discharged from hospital, a little bit stable, but still with discharge from the surgical site. And towards the end of December, I consulted some orthopedic surgeons, about three other orthopedic surgeons and a general practitioner, and we agreed that I should be taken to an orthopedic hospital where those internal coaptations would have to be removed as we try and control the infection. By this time, I was already beginning to toy around with the idea that I'm dealing with AMR. And I was thinking that it would be professional to have antimicrobial sensitivity testing to know exactly what we were dealing with and what it would be sensitive to. Unfortunately, this was never done. And I became so sick about 2 weeks later. I remember when I went to the orthopedic hospital, I was unable to sleep the whole night. And I remember all the available towels, gauze swabs, and everything became so soaked in the discharge. And at the same time, I became so septicemic, I was almost again going into a coma. My kidneys were almost failing. And then this orthopedic hospital referred me back to now the National Referral Hospital, which I went to. And then I was admitted to hospital again on the 17th of January 2021 into the high dependence unit, where again I was stabilized overnight and then kept into the ward for recuperation. Of course, again, using a myriad of antibiotics, both intravenous and oral. And after about 2 weeks, I again went to the theater. I was taken to the theater, this time to remove the internal coaptations and to try and control the infection, which was getting more and more severe. I remember the lead orthopedic surgeon commenting that during his career, he had never removed an amount of dead tissue from a human body during his course of practice, in all those years that he had practiced. And so these were removed, and again, I was put on heavy antibiotics for another period of about 3 weeks. And then, unfortunately, the following month, while I was still in the ward recuperating, I got a COVID infection. This COVID infection was almost devastating because I remember one of the left lobes of my lungs was almost collapsing. And there was accumulation of fluid in the lungs. And so one of the measures that had to be taken was to use diuretics to remove the fluids from the lungs through urine. And this caused a body loss, a weight loss of about 30 kilograms. And of course, I went through the recommended regimen of COVID-19 treatment using vitamin C as an immune booster, as well as ivermectin at that time. After about 2 weeks, I recovered from COVID, but still I had that ill feeling that I was septicemic. Luckily, I had an understanding physician, and she was able to do a culture and sensitivity testing after we had the discussion. And this time, they found Klebsiella pneumoniae. That's what I can remember was Klebsiella pneumoniae, and it was sensitive to a drug called amikacin. Now, amikacin is a drug that is both nephrotoxic, is toxic to the kidneys, and also not toxic to the ears. So it had to be administered very, very reservedly. But the infection really never went away. And in May of the same year, I was discharged from hospital in a debilitated condition and on a stretcher and on a wheelchair. So I went home in that month, and I was accompanied by a professional wound dresser. This wound dresser would come home for twice a week. He would clean up the wound using iodides, and then dress the wound and go away. In the meantime, I had a full-time nurse who was sleeping with me in my bedroom and doing everything that a nurse does to a patient. He was the caregiver, giving me the bed bath, doing all the personal effects that I required. And I lost all my privacy during that time. After 5 weeks of this wound dressing, using iodides and just cleaning up and dressing up the wound, I decided that this is not working and the infection is not going away. So I need to take action. So in the first week of August, I engaged a laboratory, and we took some samples from the surgical site for culture and sensitivity testing. And this time, what came out after 4 days was Citrobacter frundi together with Morganella morgani. And Citrobacter frundi was the main culprit because out of 18 antibiotics tested, it was only sensitive to one antibiotic. The fact that I was using all the other antibiotics, which were non-effective, did not matter much. And it just creates that notion that we were just doing a shotgun therapy kind of approach, which was not working. And so we went ahead and administered amikacin for 5 days intramuscularly. And this time, we stopped dressing the wound 4 times because the discharge went down. After about 3 weeks, we started dressing the wound twice. And by mid-September, we were dressing the wound only once. By the end of September, I took another sample for AST, and it turned out negative. And voila, I had recovered in good time for the World Antimicrobial Awareness Week, the following month of November. In the meantime, I had also engaged a physiotherapist. So I had been in my debilitated condition, started using a walker sometimes in June of 2021. And I could only walk 2 meters and then have a rest. And by the time I was going for the World Antimicrobial Awareness Week, I could walk 50 meters using the walker. So my recovery journey had started, and I went on to recover from using a walker to using double crutches, and now to use a single crutch, a single elbow crutch. And what this resulted was a 3-inch reduction in the length of my right leg, which means for it to be stabilized, I would have to use a special shoe. And officially in Kenya, according to the Kenyan government, I'm a registered person with the National Council of People with Disabilities. So I have a permanent disability as a result of AMR. That's my story.
Sorry, I was muted. I'm just saying that it is such a heart-wrenching story, John. And the amount of trouble and distress you went through, Also, you knew so much about AMR. You had researched on AMR, and still you faced such consequences. What about the common person who most of us, most of the people don't even know what is the meaning of that word AMR, antimicrobial resistance. And
Yeah.
it all started with, was when I'm listening to your story, with a misdiagnosis in the first place of a fracture. As, of course, maybe not a simple fracture, but a hip fracture, and misdiagnosed as no fracture, and that is how the troubles and problems start accumulating. You also had, just, of course, you suffered. That suffering can, nobody can ever imagine. You only faced it, but still you had the best of medical services which one could get. Again, let us compare to the plight of people who cannot even afford, or you cannot even set foot in such hospitals. Even you took such a long time, and I'm sure you must be using your experience while formulating your national plan to fight AMR. And perhaps we need to place a lot more stress on diagnostic stewardship, which again I think is not understood very well. We talk of uh, antimicrobial stewardship, but diagnostic stewardship, like diagnosing, and then, as you said, that you repeatedly felt that the drug sensitivity test should be done, mm, initially only to find out. And it was only at your insistence, perhaps, that it was eventually done. But nobody, people would not listen to a common person. You were so well versed in all in that whole field, and still it took such a long time to get proper testing done. So, what do you have to say about the responses to address AMR? Should they be more people centric, and what should we stress on? As you said, I think that is very important, that culture sensitivity testing should be done in the beginning. Yes.
Yes. Yeah, very important to point you've raised there about diagnosis. And it is very important to have the correct diagnosis at the right time so that you can use the right drugs at the right time, and to avoid this issue of using what we call shotgun therapy, using a broad spectrum antimicrobial in the hope that it's going to work. And I have seen that it's common practice for practitioners to prescribe an antibiotic, regardless of what the infection is. And one time I asked a practitioner what, she told me it's a bacterial infection. So I asked her which bacteria. And I told her, don't you think it's important to take a blood sample and do a culture sensitivity? And she told me that's not the normal practice. So I think we need to do a cultural change, a paradigm shift in our practices. We have to go right into the proper regimen of diagnosis, proper diagnosis, before instituting therapy in whatever way. It's very important. I had the knowledge. I knew exactly what was going on. I knew I was dealing with AMR, but nobody seemed to understand what it meant to do a culture and sensitivity testing, or the importance, the significance of doing that culture and sensitivity testing before administering all sorts of therapeutic agents which are not working. I remember I went through a lot of intravenous injections, and most of my blood vessels shrunk. And it was very difficult to get a blood vessel in my body. So we had to do a catheter into the aortic arc. You can imagine doing a surgery, another minor surgery, to get into the aortic arc so that you can administer an antibiotic, which is not working anyway.
Yeah. Right.
So even common people, the common man who has no knowledge of these things, is at real risk if he thinks he's at the mercy of the practitioners. And these practitioners are not paying attention to the stewardship on diagnosis before administering therapeutics.
So there needs to be a lot of education and awareness amongst the medical fraternity also, as well as the general public. I think,
I agree. I
yes.
agree. The general public has a right to know what is being done. They have a right to know whether the correct procedures are being followed. And they have a right to know what is being administered to them. By the time I realized that I had used all the first generation antimicrobials and I was still unwell, I took a look. I mean, a normal person would not really know the significance of using those first generation antimicrobials in the first place. And if you look at antimicrobial resistance, it was a direct cause of 2.5 million deaths globally in 2019. And the estimate is that 10 million would be dying by 2050 if nothing is done. And this 10 million per year, it just simply tells you that about 8 million, 80% will be in sub-Saharan Africa and Asia. So education, stewardship, advocacy is very, very paramount at this moment.
Yes, you are so right. And like your studies, your own experience is such an eye-opener for everyone to put stress on this. What you went through, even like people are dying, even those who are surviving are going through so much of pain, and of course, so much of financial crisis and economic cost, not to talk of how much money is being spent, and in a way unnecessarily. Because if that had been done in the beginning, if the culture sensitivity test had been done in the beginning, so much of trouble and pain and cost could have been saved. So
yes, you've read my mind, because the cost of the hospital bill was about 35,000 US dollars. And when I was at home, when I did the culture and sensitivity testing together with administration of the drug, it was a little less than $50.
Right.
So you can see the kind of unnecessary pecuniary expenses and impact it had, or it can have on any person if the right procedures are not followed.
Yes. But hats off to you and salutes to you for standing under the face of adversity and overcoming it, and now educating. I think that is very important, that your case should be opening the eyes of others. And I'm sure these points should be included in the national plans of all countries as they are developed or as they are revised. John, what are your expectations and message for leaders at the UNHLM on AMR, which is going to take place in September this year? That's a big event. So
Yes, it's a big event. Thank God, the WHO, we as the task force members are really focusing on this, and it is very important for the leaders to know that AMR can affect even any one of them. Those leaders themselves, they are vulnerable as well, and they are not in any way extricated from this. It can happen to them or their next of kin, and it is very important that we direct the right amount of resources, both pecuniary resources and human resources, in research and development to try and combat this monster, which is a silent pandemic and which cannot be seen, but the survivors can be seen. And we as survivors are the guys who can talk about this and try and impact the message to the leaders so that they can understand that globally this is going to be a major, major loss if it is not combated. They must direct efforts and resources to the combatment of AMR, and it has to be done now, not yesterday.
yes, very right. And also comparing the $50 to the $35,000, making
Yes.
that should make some economic sense for them, because at least that much they should be able to understand. That
Sure, yes. And also the other accompanying losses, like the
yes,
daily adjusted life years and all those losses. If you combine all those losses,
yes,
they're
yes,
really major, major losses,
yes,
and
yes,
which we can do without, and we can redirect those resources to other development projects or something like that.
yes, rightly so. And thank you very much for, uh, this has given us hope also, encouragement and strength to fight the ordeals which come in our lives. and to come out or somehow come out safely out of them. So that is what I have learned from you today. And thank you for finding time to be with us and apprising our listeners on why it is so critically important to curb and stop this rising menace of antimicrobial resistance. Friends, we were listening to Dr. JOHN KARIUKI, Assistant Director at the Veterinary Public Health Division of the Directorate of Veterinary Services in the State Department for Livestock Development, Kenya. He's also a member of the WHO Task Force of AMR Survivors, as well as the Kenyan National AMR Stewardship Interagency Committee, which develops the National Action Plan on AMR. And his words give us hope and strength